Good morning. I'm here again with Dr. John Kanellopoulos from Athens, Greece. John, you and I spoke earlier this morning about high-fluence cross-linking in combination with topography-guided normalization of corneal irregularities. But I think that one of the most important things in understanding corneal pathology is corneal imaging. And how do we know, with the various imaging techniques, what exactly is wrong with the cornea and how to treat it? So can you tell us a little bit about what's new in 2014 regarding corneal imaging?
Sure. Thank you, Jonathan, for having me and for the question. This is very, very exciting times for anterior segment surgeons. We have a multitude of options in imaging the cornea, and each one of those has advantages and limitations. For instance, the traditional placido disc reflection topography relies on a tear film. It's not necessarily extremely accurate in the center, as it has a blind spot, so to speak, in the center. Sine fluid imaging has become mainstay internationally as the means to not only image the curvature of the cornea, but also the posterior curvature of the cornea and the thickness. And then we have new players in the cornea imaging arena, such as the very pleasant adjunct of OCT imaging now, which has been initially described as a means to image the retina. It can image, and there's many companies working on this, and it's already clinically available, the cornea. So we can have imaging of the curvature of the cornea, the thickness of the cornea, and one area that's quite interesting is the cornea epithelium. So this really is a game changer for the anterior segment surgeon, as the epithelium is a new entity, and it's a very, very sensitive biological marker. It's very regular in most people.
Well, John, what does the corneal epithelium tell you on imaging that may be indicative of corneal pathology?
We have found, and we've published extensively on this the last few years, we have found that the cornea epithelium is such a significant metric for the human body that I relate it to core body temperature. It's the same on everybody at every site of the planet, and we're able to identify, for instance, dry eye by reading cornea epithelium. We can identify perhaps early ectasia, and we can identify irregularities that will help us correlate clinically cornea topography and visual symptoms. For instance, if there's a disruption of cornea epithelium post-cataract surgery, that could explain visual disturbances that patients may have that will otherwise not be explained with traditional means, for instance, topography, slit lamp exam. I think it's very exciting times, and we're also working with a new reflection topography over the last few years called the Cassini, which basically uses a multitude of color spots that are projected on the cornea, are imaged, and instead of placido classic imaging, which is correlating the central ring to the one that's outside that, and so on and so forth, these 700 spots are ray traced at triangles. So any section of the cornea is imaged for these three spots to be ray traced and give perhaps more accurate cornea curvature data.
What about in this new Cassini technology, what about the central cornea? I know you had mentioned that in placido imaging, the central cornea is often a blind spot or an area that we cannot measure well. What about in this new Cassini imaging?
This is probably the most exciting aspect, because it seems to be a front runner in keratometry for IOL calculation and central cornea irregularities. It's completely independent of any opacity of the cornea, and it appears to be more accurate in the center than traditional placido disc topography. So this may be the objective reference to relate to the central cornea, especially if there's any suspicion of opacity. And I have to note that most older patients do not have a normal tear film, may have subtle opacity, which may affect sine fluid imaging. And placido disc is not extremely accurate in the center. So I think this creates a new benchmark to correlate, for instance, laser interferometry data that we use traditionally for IOL calculation, and have a better understanding and perhaps more accurate reading of the central keratometry numbers.
Well, that's such an exciting new technology, and we really look forward to seeing it put to clinical use. Thanks so much for being with us today.
Oh, sure. Thanks for having me.